Up next, Michael Hugh Sketch is joined by Dr. Noel Bairey-Merz, Medical Director of the Women's Heart Center at the Cedars-Sinai Heart Institute in Los Angeles, California. They discuss lipid management today, unanswered questions and unquestioned answers.
Dr. Merz, welcome to ACCEL.
Happy to be here.
Dr. Bairey-Merz, as a way to start the discussion, a question that to me seems so unanswered is, how low do we go? Where do we target our LDL, or do we even target LDLs anymore?
Well, it turns out that we were authorized and actually instructed to only be evidence-based by using randomized controlled trials. So if you look at the randomized controlled trials of cholesterol management, they are all fixed dose, and the positive trials, the trials that demonstrated benefit, were all statins. So the guidelines throw away treat to goal, treat to an LDL, because none of the trials supported or endorsed that. What the trials did say was that if you use in high-risk patients a high-intensity fixed-dose statin, you'll save more lives than a lower-intensity fixed-dose statin. So we do say in the guidelines, use high-intensity fixed-dose statins in your highest-risk patients, and in your prevention patients, you can use those moderate fixed doses.
Well, what about our patients who are so focused on a target? Do we not follow cholesterol levels anymore?
So you must follow cholesterol levels, and the guidelines clearly state that they should be followed twice annually for compliance. And what I do in my own clinic is I see my prevention patients once a year, and I have the primary take it at the other 6-month mark. So they know, like, you have to go get your teeth cleaned twice a year. You need to see your cardiologist and your internist twice a year.
Is there an age target, and both on the low end and the high end, of when we shouldn't treat or should treat?
So one of the knowledge gaps, and this is a bit of a donut hole in the guidelines, is because we were mandated to be evidence-based. We don't have randomized controlled trials for patients under the age of 40, and we also don't have patients over the age of 75. So that's a real donut hole in the guidelines. And again, remember, guidelines are just that. They're guiding you. They're giving you suggestions from evidence that if you do this, you will do more benefit than harm. So under the age of 40 and over the age of 75, we have to use our best judgment, and we can do that.
What about diabetes in this population? How should the practitioner take that into account?
So diabetes is one of the 4 classes that is strongly suggested that statin therapy be utilized. So a diagnosis of diabetes is a CVD risk equivalent, and these guidelines reiterate that. It should endorse a very strong conversation between the clinician and the patient about starting a moderate to high-dose statin. Depending on if they already have a CVD diagnosis, then that would be a high-intensity statin. So diabetes is a strong indication.
It seems over the past several years we've kind of gotten away from Nonstatin therapy. But with the recent release of the Improve It data, it seems like there's been a resurgence of Nonstatin therapy. What do we know about the use of Nonstatin therapy that we can use in our practice today?
We were very clear in the guidelines if a patient is truly intolerant of statin therapy, and that probably is less than 10% in good randomized controlled trials, probably less than 5%, but nevertheless 5% is a lot of patients. You can use alternative non-statin therapies. The guidelines were finalized before Improve It came out, so we actually recommended things like niacin that in the old trials, Coronary Drug Project, as a standalone drug, did save lives, just not as much as statins do now. So I think that you'll see in a to-be-announced updated guidelines, probably ezetimibe will be endorsed. Recall, it was a very low risk reduction that took 7 years to be evident. So as a standalone drug, you would want ezetimibe. You would want to be very confident that that patient was truly statin intolerant. I think the more common use, of ezetimibe now that Improve It is out, will be for those patients that cannot tolerate, because of the myalgias, the high dose of high-intensity statins. These will be our highest risk patients. And again, remember, Improve It were high-risk patients. And for those patients, they cannot take 80 of Atorva, they cannot take 40 of Rosuva, so they end up on 10 or 20 of Alova or 10 or 20 of Simva, because they just get too achy, they just can't do it. Those high-risk people, that's probably a good place for ezetimibe as an add-on combination therapy.
While we're talking about Improve It, it seemed like in Improve It, their mean or median LDL was lower than 70. It was around 50. Should we even be looking to be more aggressive when we target our therapy with these high-risk patients?
Well, here's the fallacy of, and again, remember, ezetimibe was also a fixed dose trial. It wasn't a titration trial. There are no titration trials. There are no trials that tell you that titrating to 50 is better than titrating to 70. And the fallacy with interpolating from these fixed dose trials to these target levels is that inherently the people that will end up with an LDL of 40 or 50 started out with a lower cholesterol to begin with. And they are inherently lower risk. So they will remain inherently lower risk. It will appear that titration should work. But until we have a titration trial, we can't really endorse that strategy. And there's been a lot of time and energy and money wasted on repetitive testing, adding on therapies that didn't work, or adding on therapies that are very expensive in low-risk patients for combination therapy. That's not money well spent.
Well, when we're talking about new therapies, and it's an unanswered question, but with the anticipation of the PCSK9 inhibitors being approved sometime this year, what should be the role of these new agents?
Well, as a lipidologist, we welcome any new medication because, again, that 10%, I think it's probably closer to 5%, that are truly statin intolerant, this is a breath of fresh air if they prove to be efficacious in lowering events in addition to lowering cholesterol. It's also a tremendous breath of fresh air for the heterozygote and the homozygote familial hypercholesterolemia that, heretofore statin therapy reduces, but certainly doesn't even come close to lowering them to the normative levels that would allow them to have good, long, healthy lifespan. And we're talking about relatively young people. And heterozygous is not uncommon in the U.S. in the Caucasian population. So we're looking forward to this and hope that these big clinical trials are going to show event reduction.
So what patient cohorts would you think we should consider these in? Is this a statin intolerance group or what?
They're going to be very expensive. This is monoclonal antibodies. These are injectable every 2 or every 4 weeks. And the pricing estimates that I've seen, I'm not telling you any insider trading, you could read this in the Wall Street Journal, it's going to be very expensive. So I think it's going to probably be by insurance approval for familial hypercholesterolemia, which I just, said is more common than you think, but all things considered, not very common. And then I think there will be a case-by-case approval for very high-risk patients that have documented statin intolerance. What will that require? Well, that's authorization. So what will healthcare payers ask? I don't know, but that'll be the new problem to figure out. I don't think it's going to be a lot. Again, I'm going to say my estimate will be 10% of the CVD population or less. I doubt that it will be easy to get this approved for what we call primary prevention. The ASCVD risk score of greater than 7.5%. If this therapy is $10,000 or $20,000 a year, I personally don't think that would be worth the money, but I could be wrong.
Do we have to be concerned with these kind of agents of going too low with our LDL?
Always a very good question, has been asked and answered to a reasonable amount of repetition. For example, we've done studies in our WISE population, women with ischemic heart disease, asking the question, if you get total cholesterol and LDLs very low, total cholesterol less than 120, LDL less than 25 or 30, what happens to sex hormones? Cholesterol is the backbone of the steroid molecule. And our women had normal, including our young reproductively active women. That's just one example of what you could fear, but so far has not turned out to be a problem. It was not a problem with the high-intensity potent statins, meaning more lives were saved than any kind of adverse consequences.
Noel, if we kind of switch over to unquestioned answers, since the recent guidelines, there's been a lot of discussion about the risk calculator. Does it overestimate? Does it underestimate?
It's a good question that is not being asked, which is, in these registry populations, particularly those of Paul Ridker, the Harvard Physicians' Health Study, and the Harvard Nurses' Health Study, are these representative populations of the U.S. right now? Predominantly Caucasian, highly educated doctors and nurses, many of them already taking statins, access to health care. And in fact, it does overestimate risk in those Ridker populations. What is not asked enough is how does it perform in the multi-ethnic, multi-SES, now dominantly not Caucasian representative U.S. population in 2015. And that's the Big Regard study, Don Lloyd-Jones, and it predicts exactly right. It doesn't overestimate and it doesn't underestimate. That's not being asked enough. And the risk calculator works for the U.S. population who we're taking care of.
What about women? Do we need to take into account anything different there as far as the management of their lipids?
So it turns out we have a knowledge gap with regard to women for primary prevention. Said another way, we've not randomized enough women to, as a standalone group, not a subgroup, because again, remember, the U.S. population now is 52% women, but we didn't randomize enough women, and they are relatively lower risk than men, so there were not enough events to say it saved lives. That said, the guidelines said, because we don't have enough information, and because this is such a large group, we will currently, until we have further information, treat them the same. And we said the same thing for African Americans, Hispanics, Asians, Native Americans. Until we have sufficient evidence, we're not going to put these groups up on a pedestal and say that they should not be treated. We treat the U.S. population, which is male and female and is multi-ethnic. So the guidelines tell you to treat.
And do we have the answers, or should we be questioning more this relationship between diabetes and statin therapy?
So that's a good question that's not being asked enough because, should we put statins in the water? If they're that good, should pretty much everybody be on a statin? If you call by a show of hands in any cardiology community, how many cardiologists are on a statin? Most hands go up. And we now know there is a 1 in 1,000 risk of acceleration to diabetes associated with the statin use. The more potent statins, Atorva, Rasuva, it's more obviously evident. And so the question is, if we start to calculate 10, 20, and 30-year risks, and we start treating people at younger and younger ages, will we get to a point where the risk is the same as the benefit because of this small but significant drive to those that are predisposed to diabetes? And I think that's a big question that we need to all consider, and it's why I don't tend to treat very young patients with statins unless they are diabetic, unless they have familial hypercholesterolemia, unless they already have evident plaque.
And doesn't this relationship to diabetes highlight the importance of the discussion with the patient before initiating statin therapy, especially on the healthy lifestyle, weight gain? And
Clearly. Lifestyle, again, read the guidelines. Most people that are complaining about the guidelines have actually not read the guidelines. The guidelines remain that therapeutic lifestyle is the cornerstone of all guidelines, and then the pharmacologic treatment is just to initiate that discussion, and it's a two-way street.
And with this array of different questions, when should we anticipate the next set of guidelines, the next update?
That is a very good question. Again, National Heart, Lung, and Blood got out of the guidelines business, so we don't currently have a schedule of when we're going to be updating guidelines. That said, the American College of Cardiology is committed to living guidelines. meaning they are updated regularly. In this day and age of digital and online resourcing, there's just no reason that they shouldn't be living. I think the Improve It now endorses that as mono or combination therapy in these very high-risk groups that you and I discussed. It does not question the target issue, because again, it was fixed dose, so until we have a titration trial, that's not going to come back. And when would that happen? It's a good question, and I wish I knew the answer. We'll look to our leadership.
Noel, it's been a pleasure to have you here. Thanks for a great discussion. We look forward to having you back in the future to rediscuss the changes.
Thank you.